Thank you very much for taking the time to talk to us today. So we want to learn more about glue ear. So if we can start off by handing over to you and giving us a little overview of what is glue ear and how does it get there?
Okay, thank you for inviting me, Bridgitte. Well, glue ear is probably the commonest cause of hearing loss in childhood. It's the reason why we call it glue ear, because it's actually about mucus, and that actually sits behind the eardrum, so in that middle ear space. And its mucus is quite sort of thick and sticky, the same mucus as we get from our nose and sinuses, and it has that sticky, tenacious property, which is why we call it glue ear. And you can imagine that if it builds up behind the eardrum, that the eardrum is not going to be free to move so easily, and it can cause hearing loss. Now, the number of children that have glue ear is really quite high. There's a lot of them. But the majority of children with glue ear don't actually exhibit hearing loss. So in its very mild form, you wouldn't even know it's there. When we think about children that come to the ENT department, they've already been seen by their GP, who would have observed them for a little while and maybe treated them with something like nasal balloons. We can talk about that later. And it's that hardcore of children who don't get better with time that the GPs will refer to us in ENT. And then we observe them and make sure that they're suffering from persistent, one, that they have glue ear. Secondly, confirm that they have a hearing loss. And thirdly, we have to confirm that they have persistent hearing loss before we start treating them actively. Because a lot of children with glue ear would just get better by themselves.
And what's the kind of time we allow to let a child resolve?
We see in the old days we used to treat children with grommets the moment we see them with glue ear, but that changed because the evidence was showing that after about 3 months of observing a child with glue ear, that there was a 60% or more probability that glue ear will actually improve. So what we say is, well, let's observe them, and this is the guidance the National Institute of Clinical Health Excellence suggests, that we keep an eye on them for 3 months, and then if we can confirm this persistent hearing loss, that's when we actually act on them.
Okay. And what kind of management would you use at that point?
Well, in the first instance, as I said, the first line management is to observe them. And then at the 3-month repeat hearing test, we need to know a number of things. Do they have a disability? Are they handicapped through hearing loss? So does it manifest in terms of poor interactions with their peers, with their teachers, with their parents, and so on? And does it impact on their speech and language development? So pretty critical, and also in their academic development. So pretty critical questions. And if the answer to any of those is yes, then I do feel quite strongly that we should intervene with that. Now, in terms of surgical intervention, any further intervention, there are options. One option is the application of hearing aids. Now, hearing aids, as you know, hearing aids is an amplification device, and its use in glue ear is to provide the child with hearing while they're going through their glue ear period. So it's a perfectly reasonable path to go down. And I know that you have sensibly placed a lot of children on hearing aids, and by and large it's a very useful way of dealing with things. It doesn't require an anaesthetic, it's low risk, it's not for all children, there's a stigma that goes with it for the older children, but also they can be used to tie the child over until they're considered for grommet insertions, for surgical intervention. So the surgical intervention that we have is grommets. A grommet is essentially a hole in the eardrum. So the equivalent is, if it's a child with glue ear, if we put a little needle prick through the eardrum and create a hole, that would sort the problem out, because what it's doing is actually equalising the pressure between the middle ear and the outside world. The reason why, I should really say what the reason why glue ear happens in children is because their eustachian tube, that's the tube that connects the ear to the back of the nose, doesn't work very well. and when they get older, it starts to function a bit better. So in that sort of child group, what we're trying to achieve by making a hole in the eardrum is to equalize pressure and do the job of the eustachian tube for them. So for those that do diving eustachian tubes, we have to clear our eustachian tubes to equalize pressure that way. When we come down in an aircraft, we swallow to try and equalize pressure, or we can puff air up into our nose as the plane comes down, as the cabin pressure rises.
Yes.
But putting a hole in an eardrum, while that works temporarily, the eardrum will heal over. So the point of a grommet is to keep that hole open.
Sure.
So it looks like a cross between a rivet and a washer, or a bit like a cotton reel with a hole through it. Yeah. It sits in the hole that we've made in the eardrum and keeps the hole open. Then the eardrum keeps the grommet in, is retained, and then after about between 4 and 14 months, and it's quite variable, the eardrum then sheds the grommet and it's gone, and the vast majority of the time the eardrum then heals over. So while the grommets are in place, the hearing should return to normal.
And how often does the hearing loss return after the grommets come out? So
we're in the carefully selected patients. So we're looking at a minority of patients with glue ear, of children with glue ear that require grommets. Of that group, once the grommet comes out, it's just under a third are going to need further intervention. So maybe less than that, maybe a quarter, because in that group there's going to be children with longer term eustachian tube. So that's if we're looking at the right group.
Okay. And tell me a little bit about glue ear in adults, and how is that different, and how does that manifest differently?
Well, it's rare in adults because their eustachian tubes are much more developed.
Okay.
And but it does happen in adults, and it happens most commonly after colds and flus. So, but it can so that the infection sets up a congestion within at the back of the nose, which is the opening where the opening eustachian tube is, and then mucus builds up. By and large, that goes away after several days, but sometimes it can be retained. And I get to see patients that have had this for months, even years afterwards. And they could be candidates for grommet insertions. But with adults, we tend to try them improving the eustachian tube function with nasal steroid sprays or decongestant sprays. And that sometimes works, but sometimes not. The other important cause, when an adult has glue ear on one side, we have to examine the postnasal space to exclude a very rare cause where there might be a tumour or a cancer of the postnasal space. And that's easily checked with a very quick procedure in the outpatients with a telescope examination. Okay.
So can grommets be inserted in an outpatient setting?
Yes, we can do that. The grommets can be inserted under local anaesthetic, and normally with children, I almost exclusively always perform that under general anaesthetic because it is an uncomfortable procedure and requires a degree of stoicism to have it done under local. To perform it under local usually requires the application of an anaesthetic cream, which is instilled into the ear canal. And it takes about an hour and a half to work. So you bring the patient back after an hour and a half, clear out the cream. It desensitizes to a degree the eardrum, but remember the eardrum is a very sensitive thing. So local anaesthetic isn't for everybody. It's certainly for people with high risk anaesthetic. Say if they're medically unwell, if they've got poor chests, and not good candidates for anaesthetics, and for those that are very stoical and just want to go in and out of the clinic in the same day and don't want the intrusion of the general anaesthetic. So there's a lot of patient choice that goes with that.
Now, parents are often very anxious about surgery, anaesthetics, etc. Can you describe the procedure? Is it a long procedure?
Right, well, grommet insertion itself really doesn't take very long at all. And I say to the parents of my patients, sort of, well, I know it is general anaesthetic, but it's such a quick a general anaesthetic, and and the anaesthetists I work with are so careful, and they've got it down to such a fine art. It's almost not a general anaesthetic because the process is over so quickly.
Okay.
But of course, there's nothing in life that doesn't have any risk at all. But in terms of the overall risk, the risks are incredibly small.
So overall, a fairly quick, safe procedure.
Quick, safe procedure. In terms of the complications of grommets, there is no risk-free operation. When I say that once the grommet falls out, the eardrum heals over, it heals over 98.5% of the time. So we're looking at between 1 and 1.5% will be left with a hole that doesn't close. Now that doesn't necessarily cause a problem in itself, but can cause hearing loss and infections later on. So it's not a perfect solution. There is no real perfect solution for glue ear. The grommet can become infected.
Sure.
And something like 1 in 15, in my experience, grommets become infected, and I think that's the general accepted, published infection rate. Also, there's the issue whether children should be allowed to swim after grommets, and I think the arguments rage on there. And the evidence isn't really there for us to worry unduly about swimming after grommets. I take a rather pragmatic view to this and say, well, look, first 2 weeks, let the grommet settle in. And once it's in place and just a bit stable, then try it. Of course, if the child then says, well, it hurts their ears to swim, or the grommets become infected after swimming, then that needs to be treated. You need to treat the infection. After the infection's been treated, you say, well, look, you have to be really careful thereafter, and you can use earplugs or just avoidance of swimming if you're concerned about it.
So earplugs come in all shapes and sizes. Parents can buy some online or have some custom made. Have you had any experience on what parents prefer? Okay,
there is a practical way of keeping the ears dry whilst showering or bathing, and that is to mix a pledget of cotton wools, one of those cotton wool balls, split them into thirds, mix them with Vaseline, and then use them as a plug. Best not to use cotton wool on its own because it draws the water in, but the Vaseline makes it water resistant. So it's a very practical solution. So use scrupulously clean hands, make them as a batch. Very useful. And then there's the children that want to swim with plugs. There's a number of proprietary versions of it. So putty buddies, which go into the ear, and an ear band. It's a neoprene strap that goes over the top. In my experience, the best way, sort of for those that actually aren't getting on with these, the best way is to use a hearing aid mould and ask an audiologist to make a hearing aid mould because that really is a bespoke mould that will give a watertight seal, and that can be used in conjunction with the neoprene strap as well.
Is there anything else you want to add around glue ear or anything we haven't covered?
Well, I suppose, yes, it's what you do while you're waiting, and the NICE guidance is quite clear on this now, that antibiotics, nasal steroid sprays, antihistamines, Montelukast, they don't work, and they're not recommended. Oral steroids, definitely not recommended. There's a product called Otavent, which is a nasal balloon. There seems to be some evidence, which I will concede, actually does seem to, the evidence does seem to show that there might be an advantage to some children. The children find it fun. There's a little device they place in the nose, they hold one side, they blow up a balloon. It's effectively forcing air up a eustachian tube. But I do sometimes wonder if that really is the goal, because the eustachian tube isn't a rigid tube. It's an active tube with little hair cells that move air around, and I'm not sure if I entirely approve of forcing air up a very finely physiologically active tube. But there is some evidence that it does work.
That it can work, Super. Well, thank you very much for your time today, Adam, and I'll be in touch with any other questions.